All right, so I think we can get started. Hi, everyone.
All
Thank you so
right.
much for joining us tonight. We're really excited about tonight's talk. So I'll introduce myself. My name is Jyoti Nanda. I work with UTIVA Health, and we also have my colleague here, Derek O, who is one of the co-founders of UTIVA.
Hi, everyone.
And before I introduce Dr. Ashley Girard, I'm just going to do a quick review of today's agenda. So the presentation will be about 45 minutes at the most, and then we will move into a question and answer period. So just throughout the presentation, feel free to add any of your questions into the chat. We will be making a note of them and creating a list, and then we will get to those questions at the end of the presentation. So Q&A will be about 15 to 20 minutes at the most. And then after that, we will do a live raffle for the Amazon gift card. So just make sure you're present in order to actually claim your prize if you win. And then after that, for anybody who is interested and wants to hang on, Derek and I will be chatting a little bit about our portfolio at UTIVA. Okay. All right. So everybody, I want to introduce you to Dr. Ashley Girard. Dr. Girard is a naturopathic doctor in Ontario, and she is a graduate of the Canadian College of Naturopathic Medicine. She's a member of both the Ontario and Canadian Associations of Naturopathic Doctors and an associate member of the Canadian Urological Association. Dr. Girard is the owner of Holistic Bladder Care, a telemedicine-based practice with a focus on female bladder and pelvic conditions that stem from her own struggles with recurrent UTIs and bladder pain syndrome. To Dr. Girard, every patient is treated according to their unique presentation that respects their beliefs and empowers them to solve their health concerns. She collaborates with practitioners globally in order to help patients access effective treatment options with the goal of achieving a better quality of life with these conditions. She also has additional training on hormone balance, digestive issues, thyroid diseases, and other chronic pain conditions. Dr. Girard is passionate about educating her patients, finding root causes of disease, and inspiring change that leads to healing. So welcome, Dr. Girard. We're so happy to have you here. And with that, I will pass it on to you.
Thank you so much, Jyoti. And Derek, UTIVA, everyone, for giving me the opportunity to talk to my profession about something that is very near and dear to my heart. As you heard Jyoti telling you about, I've had issues with this in my own life, and it has inspired me to really help the women that are struggling in this area, because it is very underserviced, and patients are just so appreciative to get help in this category. So I hope today that you all learned something really valuable for your practices. Thank you again for taking the time out of your busy days to join me tonight. So, all right, so let's get started. I am going to start with the basics, right? We want to define what a recurrent urinary tract infection is, who the patient population is, and just do some of the basics, some of the basic review, and yeah. So uncomplicated urinary tract infections happen in women who have no abnormalities in their urinary tract. Two or more acute episodes in the last 6 months, or 3 within the last year. And of course, some women have them much more frequently than that. And we do want to see symptom resolution between infections, or very minimal symptoms in between that we might be able to associate with a different concern that they have, or a different diagnosis. Women with anatomical abnormalities, functional abnormalities, are considered complicated recurrent UTI patients. And if it's a UTI in a male, it's always considered complicated and needs additional workup. So complicated UTIs also include, pregnant women, women who are immunocompromised, anyone obviously using a catheter. If they have a multi-drug resistant pathogen, we wouldn't necessarily think of that as a complicated case, but it actually is and does require further workup. And also if they have a persistent infection that just keeps coming back. Kidney stones as well, diverticulum, lots of different things place women in the complicated category. We will be mostly focusing on uncomplicated, but there is, we will talk a little bit about complicated UTIs as well. So we want these to be culture proven preferably, and we would like to see the pyuria on the urinalysis. So it doesn't have to be culture proven if they've had multiple cultures and it's always the same organism and it's, you know, a long track record of this issue, but preferably should be done as often as can be done, right? Unfortunately, sometimes these happen in the middle of the night and patients can't get a sample to the lab or don't have a collection specimen available to them. So we do want to keep in mind that infections are the standard urine culture does have its problems as well. Although culture proven preferably, the standard urine culture is estimated to fail 30, I've heard up to 50% of the time. So, and that's a very complicated issue that has to do with the fact that not all pathogens culture very well. Some are slow growing, some don't culture well on the standard medium at all. These are definitely the more rare cases, but it does happen, and it's important to keep that in mind, even if a patient has the typical presenting symptoms, but they're culturing negative. And we do also want to make sure that the culture is done with a good sample, hopefully a first morning urine or a urine that's held for longer, not overly diluted. You know, as soon as someone starts with UTI symptoms, they do start to drink a lot, and that can dilute down the sample that's actually submitted to the lab. So keep that in mind as well. Symptoms are still the most important thing to be following. Let's do a quick review of the labs. So Canadian labs, we're going to see it's going to be termed an infection if they're greater than 100 times 10 to the power of 6. And this is in CFU per liter. If you have someone who has an American lab, it's actually reported in CFU per mil. So it's a lower cutoff, 1 times 10 to the power of 5. It's not a lower cutoff. It's a different reporting unit. So it looks like it's less, but just different units. And just so everyone knows here, that particular cutoff was established over 60 years ago. So there has been research that has been coming out that indicates that a lower threshold is potentially more appropriate in select patients. And this is even in the most current 2019 recurrent UTI guidelines that was produced by the American Urology Association, Canadian Urology Association. So that's something that's really important to consider, is that even within that document, they are recognizing a lower threshold for diagnosing an infection in appropriate patients. However, that has not trickled down to the labs per se. Unfortunately, there isn't a lab that is currently giving us that lower value. They might give a little bit lower, but not down to that threshold. If you have a patient that you really suspect this is going on, you can, once you know that they have submitted the culture, you can call the lab and see if you can get more information about what the microbiologist is seeing in the urine culture. The urinalysis is very important. The pyuria, which is the leukocytes, we may see blood, may not. The nitrites, if they're positive, very indicative of an infection. There aren't really any other things, unless it's a contamination issue, that are going to create a false positive on the nitrites. It's often not there because some organisms just don't produce it. Even some types of E. coli don't produce it anymore. Urine microscopy is also very useful. I always try to check off all 3 when I'm putting in my Life Labs requisitions, so that I get that view under a microscope, because sometimes they see crystals, sometimes they see the urothelium shedding, and that's valuable information potentially. So, okay, so this is just a quick slide on what the commonly accepted most common pathogens are. 75% potentially E. coli, and then much lower percentages of all the others. And let's also go over some demographics. This affects women of all ages, races, ethnicities. There's no impact of socioeconomic status or education level. Rates do increase with age. The older we are, the more likely we are to get recurrent UTIs or UTIs in general. And 60% of women, all women, will have an acute UTI, at least one in their lifetime, 1 in 20 for men. And of that 60%, 20 to 40% of those will go on to have another one, often within a short period of time, which does technically fit that diagnosis of recurrent UTI. However, of that 20-40%, only about 25-50 of them actually go on to to have recurrent, like chronic long-term UTIs. So this is a billions of dollar problem globally. Antibiotic resistance is rising. We do need other tools in order to prevent these infections. It's very important. The pathogens, unfortunately, they can evolve much more quickly because they can divide so rapidly. So they are able to build that resistance, and that's a serious situation. So, and also it is the most common adult bacterial infection globally, and the most common ER diagnosis in women. And just a quick review of the symptoms. The onset of dysuria, so pain and burning, that's one of the hallmark signs that we want to see in patients, but to a lesser, and then also in addition, urgency, frequency, we might see blood, might see some incontinence. Older adults, it does get less clear. Dysuria is still predominant, but there can be more weakness. And in our patients that have dementia, we might see more psychosis. Other symptoms: fatigue, malaise, weakness, cloudy urine, malodorous urine, vaginal burning, pelvic discomfort, nocturia, peeing at night, pelvic pressure, urine flow abnormalities as well, a weak stream. Seeing weak stream might, if it doesn't fully clear up, then you do want to consider more of the complicated UTI might be happening. And then of course, if we see low back pain, fever, it's pyelonephritis, kidney infection, send to the ER, sepsis risk, right? This is out of our jurisdiction. So let's move into the pathogenesis. Typically, it's a bacteria adhering to the urethral lining, migrating up with their various, fimbriae and pilla, attaching to the urothelium and infecting the lining of the bladder. Our immune system activates. That's where the symptoms come from. The urothelium sheds, and then it has to heal. So that's the basic occurrence in a UTI. So, but we want to ask ourselves, why are some women getting them recurrently? Why do they keep coming back? And as NDs, I feel like this is really where we focus, and we want to get to that underlying cause, so that we can correct it and we can help patients move on without getting these infections and continuing the cycle of infection, antibiotic, and what ensues from that. So right now, we still actually need a lot more research. For a long period of time, we had antibiotics that worked very easily, and it wasn't, we weren't building resistance to them. And now that that's happening and recurrent UTIs are becoming more of a problem, it is actually increasing with time slowly. More and more women are becoming prone to recurrent UTIs. It's very important that we start to do this research. So in one really interesting study that came out in 2015, it actually showed that there was a lower diversity in the urinary biome preceding a UTI and then the bacterial interference created the UTI. So that's really important, right? As NDs, we often look at the gut. We know that insufficiency dysbiosis in the gut is something that predisposes to many problems. And now we're seeing it the same in the bladder. Lower diversity means less resilient, right? And we had another study in 2021 that showed that the gut, the vagina, and the urinary bladder biome is a trifecta of anatomical sites that are implicated in the pathogenesis of UTI. So we know these three areas, we need to have them all working and healthy in order to prevent a UTI from happening. And then we had another study just this year that came out of MIT and Harvard, and it was really good to finally see that repeated antibiotic use does lead to gut dysbiosis, which then precedes to another UTI. The antibiotic was able to kill the uropathogen, but not necessarily kill off what was existing in the gut, and then that eventually made its way back to the bladder. So that one's really important, right? That's the cycle that a lot of women end up on. There's also interesting things about how the bladder heals. The Th2 skewed response is not helping the bladder heal. So Th2 response in the bladder is normal. However, what we see in some women that often go on to recurrent UTI, there's an overactive Th2 response, and it leads to tissue thickening and therefore bladder dysfunction because of that thickened lining, which then promotes the adhesion of another uropathogen. We also have a study on vitamin D3 deficiency. So this in itself doesn't necessarily trigger the UTI, but after especially in E. coli, what can happen is if you have a vitamin D3 deficiency during the infection, the urothelium doesn't knit back together properly. The tight junctions don't come back together. So that was a really good one. Shows us the importance of vitamin D3 for preventing the recurrence and improving the healing. There's also other vitamin and minerals that have also been looked at. Vitamin A more so. Ooh, went too far forward, sorry. And we do see higher rates of UTI, recurrent UTI in systemic chronic inflammation conditions, immune dysfunction. So that's also contributing to it, right? If the immune system is not working, then then we're left more prone to UTIs. And another interesting study in 2017 actually showed that the bacteria from one reservoir can work in concert to improve the pathogenesis of another bacteria. So in this particular study, Gardnerella in the vaginal tract improved the pathogenesis of E. coli and allowed it helped it adhere better and create an infection. So that was really interesting as well. These bacteria, they want to survive too. So the persistent embedded chronic UTI infection is definitely something that happens. It's less common. The theories around this is that the bacteria somehow gain entrance intracellularly, and then they stay there, and then they cycle between active and quiescent stages to cause reinfection. So that's a more difficult situation to treat. Or there are biofilms that some of the bacteria potentially make. And usually this is in relation to the biofilm usually has to form on something like scar tissue or kidney stone or crystals in the bladder. Catheters are a well-known source of how biofilms form in the bladder. So that's there, and it allows the bacteria to adhere to it and create a biofilm, and also calcifications if they're found in the bladder. So this is just a quick slide from Live UTI Free. You've got floating bacteria, and then the bacteria land somewhere else on the bladder and they cause a new infection. But where did those free floating bacteria come from? It may have come from a biofilm. So that's more in the persistent. So we're going to go back to focusing mostly on the uncomplicated, right? So these are people that have a normal non-culturing standard urine culture in between infections. So where do these bacteria potentially come from? And as we've already discussed, the dysbiosis within their own body, so the vaginal biome. And just to make a quick note, you don't have to have a positive vaginal swab in order to have a dysbiosis in the vaginal biome. Patients may have no symptoms or very little symptoms that they're aware of. Just like with the gut, right? We're often told in lectures that the gut biome, don't assume that just because they don't have any digestive symptoms that they have a healthy gut. Skin even as well. I wanted to include it because it does come up every now and then. Improperly cleaned intimacy devices end up re-inoculating the individual. And then to a lesser degree, this does happen, invasion. So re-inoculation dysbiosis versus invasion. So invasion is when there is a bacteria from the sexual partner that gets introduced into the bladder through intercourse. And this can actually come from multiple different areas. Their skin, their semen, their prostatic fluid, their saliva if they're doing oral intercourse, and even just in general, their biome, their hands, their gut, improperly cleaned intimacy devices used on them and then used on their partner. So there's lots of routes for these bacteria to come. I always include it in my intake to check in with the health of their sexual partner or partners and make sure that we're having that discussion. And the other part of this is, if there's no intercourse, right, how do the bacteria get there? There are motile bacteria, right? This is part of how they climb up into the bladder. They can also climb across the perineum from the colon and reach the urinary system. And there's then versus mechanical inoculation during intercourse, just by the act of intercourse. And the other thing I wanted to just throw in here is that, because where did bacteria come from, right? If they have a relapse after they've been treated with an antibiotic and it happens very quickly, we have to be thinking that it's more that there was treatment failure as opposed to a new bacteria or a new event. Okay. So next one, and I just wanted to put this in here because this is kind of what happened to me, and I just want everyone to understand that these repeated infections over time can predispose to the development of chronic inflammation in the bladder, often leading to a diagnosis of bladder pain syndrome, IC. IC is more related to ulcers in the bladder now, but we now call it BPS/IC. So constant symptoms, potentially to a lower degree, that look like a urinary tract infection. The standard urine culture starts to fail. And there are urologists out there that have recognized we're failing bladder pain syndrome patients by not recognizing the potential lower threshold of the standard urine culture, right? So that's, again, something to keep in mind. And this is just a quick slide on the link to the gut microbiome, the dysbiosis that can lead to recurrent UTIs. So if you want to go back and see a little bit more about that study. And this is just a slide, a big slide about all the different causes and triggers. I just wanted to get it in one place. So really important to make sure they're hydrated, right? We want to see clear to slightly yellow urine except first morning. This is really important. I see a lot of patients who get a UTI because they drank coffee all day and they forgot to drink, or they were traveling, they forgot to drink, or just didn't want to because they didn't want to pee, didn't want to pee during the car ride, and then they ended up with a UTI. So bladder holding, right? Bladder holding is not healthy for the bladder. We need to urinate probably about at least every 3 hours-ish in order to flush out bacteria. It helps keep the system healthy. Hygiene is, of course, really important. Most patients in this category have already been told half a dozen times to wipe front to back, but it's still always good to make sure that they're doing it. It does actually come up every now and then that someone isn't. Dysbiosis, like we've already discussed. Intercourse, discussed. Stress. Stress, if you talk to a lot of patients who get into recurrent UTIs, it's usually often preceded by a lower event. And we do know that that stress lowers the diversity in the gut and vaginal biomes. So we don't have the research yet because the urobiome is still so new, but I won't be surprised if we find that stress also lowers that biome. And because all three biomes are so linked, it's very likely what's going to come out eventually. Genetics, some women are more prone to recurrent UTIs, more susceptible to the bacteria. Maybe don't have all of the same proteins in the lining of their urothelium. That makes them more prone to it. Swimming, a lot of women get this, triggered from swimming. Chlorine in pools. Chlorine can impair the immune system. It might be related to that, or it might be related to a bacteria in the lake that they're sensitive to. I do have women use a barrier before going into water if they have this problem, and always urinating after swimming. So, and that tends to really help them in that category so that they can enjoy the water again. Fragrances, right? The bath fragrances, bath bombs, and bubble bath, right? This is linked to recurrent UTI. It probably is a patient who's sensitive to these chemicals. It creates inflammation, and then that inflammation encourages an infection. Menses sometimes does it. Again, this could be feminine hygiene products, and the fragrances or the chemicals used on those could be menstrual blood, changing the pH of the vaginal biome and encouraging a bacterial pathogen to start to grow in more so than what it would have been while the lactobacilli was predominant when there's no menstrual blood. And then, of course, hormones, right? So getting really specifics from patients to try and tease out what could be going on, and making some simple changes might also help them. Synthetic fabrics, thongs, these are triggers. Vitamin D3 deficiency, we've discussed. Antibiotics, vaginal infections, Mycoplasma infection. This is one that is not tested under the standard urine culture, so you do have to run that. And we are, as NDs, we can run that particular test. Make sure it's a first stream urine. When you're testing that, it does cause urethritis, and that can sometimes be part of the problem. They can have that inflammation from the other infection, and then that encourages the uropathogen to gain entry. Constipation, SIBO, IBS, diarrhea, any sort of gut dysbiosis or symptom can potentially encourage uropathogens. Constipation is more related to an overgrowth of bacteria in the colon because of that excess stool content. Diarrhea is more because they're going so frequently that it's exposing their perineum to residual stool all the time and bacteria. So that happens. Same with hemorrhoids. A really poor diet. We do know that certain types of diets or don't support the gut. They make a dysbiosis. Sugar encourages candida. There's also oxalates to consider in this because oxalates are crystals potentially spilling into the urine. Different patients need different dietary advice based on what you think that underlying cause is. And an acidic environment creates more inflammation. Alcohol, right? Inflammation. Anytime we increase the inflammation in these patients, it can trigger a UTI potentially. I'm just going to take a quick sip of water. Okay. So perimenopause and menopause, right? Because we see the decline of our estrogens, vaginal atrophy, atrophic vaginitis. So it's now being recognized that we should be considering vaginal estrogen in perimenopausal women. This is right in the recurrent UTI guidelines now, which is great because before it used to just be menopause, but that's not realistic, right? We see women long before they hit menopause decline in their estrogen potentially, and also even past. It's now being recognized that starting vaginal estrogen greater than 10 years after menopause is acceptable when there are genitourinary symptoms that are bothersome. So that's just a discussion you have with the patient. And also other hormone issues, right? If there's an estrogen excess, we see actually more candidiasis, yeast infections with estrogen excess because it can potentially impair the immune system. So that's something to look at. Breastfeeding, low estrogen, that can be a trigger for some. And high and low cortisol, that's important to look at too. High cortisol, we've got a catabolic state that's happening. People aren't healing very well. There's a loss of hormones to other systems. It definitely doesn't help. And of course, when women are in this cycle and getting infections, it's very stressful. So I do see a lot of high cortisol in these patients. And sometimes low cortisol as well. Right now, we can't mount a good inflammation response, a normal inflammation response to typical triggers. Vaginal dryness, this is a problem. The friction creates inflammation, which can then encourage that dysbiosis and that infection. And inflammation. Allergies, I'm more referring to like the allergies to fragrances or foods potentially creating that inflammation. Some women get infections after they've had a cold. It just, again, their immune system is busy doing something else and it triggers a weakening somewhere else, and then they get an infection. Kidney stones, I've mentioned earlier, and then pelvic floor dysfunction, neurological dysfunction. These don't help the situation and need to also be looked at for the urinary symptoms. And okay. So I wanted to cover a little bit on the urinary biome. We've only really known about it since 2015. It does vary by gender, sexual habits, and partners, hormone status, cycle timing. In a healthy cycling woman, the predominant bacteria is Lactobacillus crispatus, and what some of the researchers are concluding is that the phenolactic acid that it's producing is helping to suppress those uropathogens. And they've seen that this particular type of lactic acid is even effective against multi-drug resistant bacteria. So that there's more research being done on this particular strain. You're probably going to hear about it in the future, and there may be more supplements available with it coming in the future. So the main, even just to make sure everyone knows, some of the uropathogens are still common in an asymptomatic control to a threshold, right? When a body is healthy, it can actually manage these particular bacteria and keep them at a lower level, a non-pathogenic level. So that's important to know as well. And we do see a lower diversity in patients treated with repeated antibiotics. And also, recurrent UTI is frequently polymicrobial as well. So although a lot of the research says 75% E. coli, it actually is, when we do more advanced testing, it actually indicates that potentially there is only about 50% E. coli, and then the other 50 can be potentially other pathogens that just didn't culture well on the standard urine culture. So this is a quick slide from some of the research by Dr. Wolf. And as you can see, the non-LUTs at the top left is that those are healthy individual non-lower urinary tract symptom patients, and then versus the UTI patients, quite a different urinary microbiome going on. So we're really looking forward to more research in that category. All right, so let's talk about management. Patients, what do they experience? Get their first acute UTI, no big deal. They're given an antibiotic. It's just this short course. They take it, no big deal, hygiene advice, right? And then they start coming back and they get it again. And then they start to see triggers and they get more antibiotics, maybe the same one, maybe different, maybe more broad spectrum, maybe a longer duration, a higher dose. And then over time, women often start to get vaginal infections because of the UTIs. Sometimes they get the development of digestive problems. They get more allergies. They start to develop, signs that is suggestive of leaky gut, more food sensitivities. And then, of course, the really scary stuff like C. diff episodes, organ toxicities, and especially, Cipro has had a lot of negative impact on UTI patients who have taken it. There is a call to not use it anymore, but that's that's up to the doctor, right? But anyways, reduced quality of life is very common. I hear it all the time from my patients. I so feel for them. There's a lot of fear about developing antibiotic resistance. What if I don't have an antibiotic that works eventually? What if I get a kidney infection? There are people that, especially in the older age categories, that do die of UTIs. It's not very common, but it's a fear, and there's a lot of frustration. There's a lot of disappointment with the long-term management, because every time they go to their doctor, it's just treated like another UTI. And sometimes they get a referral to a urologist, sometimes they don't. And it's just, there's no real long-term management. And there's a lot of trying to fix it themselves, unnecessary behavior changes. And then, of course, loss of intimacy if intercourse is a trigger, which it often is, and even loss of relationships. So really, really important to try and get this, addressed for patients. So let's go over a couple of things that I like to focus on. Setting expectations with treatment. So we're not telling patients you're not going to have a UTI ever again, right? It's about UTI reduction. And hey, maybe we will be able to eradicate them, right? But we want to focus on setting the right expectations so patients don't get upset when they get another UTI in the course of treatment, and helping them understand that this is a long-term strategy, because potentially everything they've done before, we need more time to fix these things potentially and investigate, right? Meeting the patient where they're at. If they do want to use antibiotics for therapy for their acute UTIs, that's absolutely, support them, give them ways to mitigate the effects of those antibiotics, and then focus on that long-term strategy for correcting the issue. Of course, we do want to reduce it, though. We want to reduce or eliminate that antibiotic use, because that's creating the dysbiosis that continues them in the cycle, and giving them informed consent about those risks with their antibiotics, and all this other information I'm going to give you here today. I'm just going to have a quick drink again. All right, and I do like to provide self-management tools for patients. So actually had this out for a patient today. So I do teach patients how to use the urinalysis strip so that they can start to catch infections more quickly and then self-initiate therapy before it gets so bad that they need an antibiotic. The anti-adherents and some of the antimicrobial herbs, they do work even better when there's a lower load, much easier to clear and get them back on track so they don't end up with an antibiotic or needing an antibiotic. And again, that acute UTI management versus the long-term strategy, and helping them understand, what the main goals are for rebalancing their health, treating other pelvic infections, etc. So we do want to do our pelvic exams, our vaginal swabs, STI panels, mycoplasma testing, right? Then there's a whole bunch of other imaging a urologist can do. We've mentioned the nutrient testing. There's advanced DNA testing that can be done in the States to determine if there's that low-grade infection, partner testing, advanced testing. And then really, this is part of the management as well, is repeat testing, right? If you find something that could potentially be the underlying cause of their recurrent UTI, then, once you initiate therapy, repeat testing, and make sure you have that conversation right from the first time. You tell them, I want you to do a Dutch test for your hormones, and let them know, in 6 months' time, potentially we are doing another one, because if we find something, we need to check to make sure that we have corrected that issue and it's not part of what is currently the underlying cause. Get as many details as you can, all the timing of their triggers, what preventative measures work, what haven't worked, what doses they took, right? Vaginal health, gut health, and discussing intercourse. So life therapeutic order, really important as naturopaths, right? We want to start with the lifestyle and diet changes, hygiene, fragrance removal, and then trying the anti-adherents to try and see if that stabilizes things while we're working on that underlying cause. Herbs to potentially treat the acute infections, and if that doesn't work, then they potentially move on to an antibiotic. There's another medication called Hiprex, which is really neat. Antiseptic, can't form a resistance to it. It's not an antibiotic. It's a little bit different and available in other countries. And then potentially prophylactic antibiotics end up getting used. And if there's the antibiotic that causes the least dysbiosis, it's macrobid. So I just want to put that out there. And can they go away on their own? Actually, they can go away on their own. This is part of informed consent, right? So if a patient asks you this, 25 to 50% will resolve or spontaneously improve in 1 week without using antibiotics. So that came out of a study. The body can recruit these white blood cells to fight the bacteria, but it generally applies to mild and non-recurrent infections. So just wanted to put it out there if a patient asks. And 1 to 3% of all acute UTIs ascend to the kidneys. So it's not very common, but it does happen. All right, so prevention, right? In order to get patients so that they're not continually on the cycle, we have to prevent the infection. And while we're working on those underlying causes, right? Especially if one good example is Cipro is a very broad spectrum antibiotic. If that's in their history, then we know that in order to fix their dysbiosis, it's going to take longer, because there's research that indicates there's a dysbiosis after Cipro use, even a 7-day course, for up to a year. So it's just a really, really, again, those broad spectrum antibiotics, if that's in the history, it may prolong the ability for us to reestablish normal flora, and using diet to reestablish as well, of course, right? Lots of great fiber. So in the meantime, in all types of UTI, whether it's uncomplicated or complicated, we need to prevent the episodes as best we can so that we help to improve the chances of their body recovering. So using a product that is high dose, 36 milligram, is potentially going to have better outcomes in some patients. And one of the things that I really like about a product that's higher in proanthocyanidins is that there's a 24-hour half-life to them. So they take it once. D-mannose, I use D-mannose a lot in practice, but it is a shorter half-life and they have to take it more frequently potentially. So I like the 24-hour effect. So they just take it one time a day. And it also targets multiple organisms, which again, D-mannose is E. coli. There's some research saying maybe Klebsiella, but the proanthocyanidins can stick to more things, which is really useful. And this particular product is low in oxalates, right? Cranberry is safe in pregnancy. So even in those complicated UTI patients who are pregnant, this is a strategy that we can use and help prevent them having a UTI while they're pregnant, which nobody wants that in addition to already being pregnant. Just a sec. Okay, so the other part of this is that there are soluble PACs versus some that become insoluble. So if a supplement isn't prepared properly, some of the excipients can bind to the PACs and make them insoluble, and therefore we can't absorb them and we don't get their benefits spilling into the urinary tract. So keep that in mind, and it is important to have products that are third-party tested in general across the board so that we make sure that what we're giving patients is what they're getting, right? And you may have heard of proanthocyanidins from grape or green tea, and these are actually a type B PAC. So, and the research for them indicates they're not very anti-adhesive. They may have other great benefits for patients, but it's not necessarily in this capacity. So the type A PACs are the ones that are shown to be anti-adhesive. So here's just a slide on UTIVA's product in general. I think I've covered most of this information. Some of the research around it, the 36 milligrams, this is a really great study that even in complicated urinary tract infections, we can see a really good reduction in uropathogenic bacteria in their urine cultures by using the 36 milligram PACs one time a day for 6 months. Almost a 60% reduction in uropathogenic bacteria, which is really great. Urine white blood cells fell by almost half, and really even more interesting if you haven't heard about this, but the the bacteria can actually deprogram their resistance. So if they're not provoked by antibiotics all the time, they actually start to lose that antibiotic resistance that they may have developed. So that's something that they actually saw in this study, almost 30%, and no adverse effects, very well tolerated, which needs to be factored in as well. So how do they work? They stick to the fimbriae on the bacteria and prevent them from being able to adhere to the surface of the urothelium. And another thing, you probably will have a lot of patients that come in and say, oh, I drink cranberry juice. Well, we know as naturopaths, cranberry juice is really high in sugar. It's not really great for their biome, and, spiking blood sugar, it can improve uropathogenic bacterial abilities to infect anyways. We see more UTIs in diabetics. So it's not really the best way to go. If it works for them, of course, right? If it's a cheap thing that works, then it's working. But using something that is not high in sugar is in my opinion, better. The other part is if you have patients who have IC, then oftentimes they'll say cranberry is a no for IC patients. And that is true, that's because cranberry is high in acids, and acids irritate an already inflamed bladder. So using, again, a product that is low in organic acids is going to potentially be something that can be used in those patients that have bladder pain syndrome, but also have recurrent UTIs, which happens frequently. So that is that guy. The proanthocyanidin content in many products is very, very low, and there is the possibility you need many pills of another product to have that same dose that can benefit them. And of course, I mean, our patients, they want us to be giving good products that have a higher chance of producing the outcome that they want, of course. This is a quick slide on some variety of other brands and taking a look at that anti-adhesive score and the PAC content in them. And some, I mean, had too low to even measure. The highest one was 5. versus, what the 36 milligram product should have. Here's a quick slide on efficacy, different result or different trials. If you want to look at more into the benefits of cranberry, the one really important thing is to have patients double it. I just say after trigger, double it. So they take 2 after intercourse, 2 after swimming, and then 2 the following day. And that extra amount of the PACs, it just means that there's more of them there. They can bind, they can stick to more bacteria if there's that influx of bacteria from the trigger. And then it helps the patient urinate them out and they don't get an acute UTI. So D-mannose is another great one. It's more, like I said, more of a shorter half-life. And I do like to use it for patients where, they just always see E. coli. It doesn't seem like there's multiple pathogens present and they know it works for them. They've tried it before, they know it works. And then it's just about giving that education piece, right? That they can take it more frequently because it is very safe to take frequently. The worst that's going to happen is maybe a bit of diarrhea, and it can help flush out that bacteria quickly. So the D-mannose sticks to the type 1 Fimbriae of E. coli. And keeping in mind, though, that it's not going to work for everybody. Sometimes E. coli, like there's potentially more than 300 different types of uropathogenic E. coli. And there are some that probably have de-evolved this particular Fimbriae because I've used D-mannose and some patients just don't respond to it at all, but a lot do. So again, these pathogens, they're very smart and we just have to keep working with patients and helping them to find the products that are going to work for them. I really liked this product or this trial, really good, cranberry or trimethoprim. And although, so of the participants, some of course got a UTI during treatment, but 25 in the cranberry group, 25 in the cranberry group did, 14 in the trimethoprim. So it was a little higher in the cranberry group, but the amount of adverse effects didn't outweigh the choice between them. So and it obviously didn't have an antibiotic risk. So the slight benefit over trimethoprim was outweighed by the adverse effects. So keep that in mind. And that was also in older patients. Lactobacilli, really good, but not recommended highly in the recurrent UTI guidelines right now because of the lack of evidence. But there was a systematic review that did include a couple of studies, and overall the results are positive when we select the right species. It's just we do need more information, but we do need to correct that dysbiosis, right? So doing that with the right species is really beneficial. Vaginal estrogen, really important. Like I said before, in many different stages of life, we can try to improve vaginal estrogen. We can try to improve it, with our herbs and our diet as well. But I am a big believer in bioidentical hormone prescribing, and even sometimes in combination with Biesta as well, if they've got those systemic symptoms. And this is a quick slide on the lactobacilli adhering to the this is a quick slide on the effect of estrogen on the vaginal tract, improving the acidity of the vaginal tract, and then preventing the bacteria. And then those bacteria don't easily get to the bladder. I wanted to mention Uroimmune. This is coming potentially next year. This is an oral urinary vaccine. So really cool. This is already being used in the UK and other European countries. And we've got the research here now. Health Canada has this in their hands. So this is going to be a really important thing for patients to know about in the future for next year. So that's just a quick summary. And UTIs, here's a quick case. Here's so a 24-year-old female. This is one that I think we all see a lot. She was getting lots of UTIs, has since she was sexually active, really severe symptoms with her UTIs, monogamous relationship. And unfortunately, she had actually had no cultures. She was just given antibiotics over and over again, and post-coital antibiotics, 2 weeks to recover sometimes. And she was chronically constipated. So she had tried a few supplements, but not much. So I put her on the 36 milligrams of PACs. We had D-mannose as backup for acute treatment. And because I think she for her, it had worked in the past. It just, again, she needed more information about dosing. We fixed the constipation, fiber, lots of probiotics, and lots of good hydration. And in 6 months' time, she had one little flare up that she managed with a little bit of baking soda, D-mannose, and over-the-counter pain medication, and it was gone the next morning. So I'm very happy there. Here's another quick case. So a 40-year-old healthy female, very healthy, working out 6 days a week, and she was getting a UTI, very sporadic, and then they became more frequent all of a sudden, and they were getting very severe. She had been on multiple antibiotics for the last one before we started working together, and it was always E. coli. She had stopped working because it was taking such a toll on her life. And she was really pushing when she was peeing, and that's part of what happened. She developed lingering symptoms afterwards, and it was actually the pelvic floor dysfunction that she had created by pushing. And just very tearful, fearful, weight loss, panic attacks, hot flashes, intimacy avoidance. So we did find on, pardon me, we did find the low estradiol in her case, low vitamin D3, low LDL, which is a precursor to her own estrogen. She was working out a lot, and very high cortisol. And we worked on all those different facets. She brought down her inflammation, did the estrogen therapy, and 6 months, no UTIs, and we're having regular intercourse now, sleeping great, feeling great. And this is a case where we used both topical Biest as well as a vaginal estrogen at a very, very low dose. And she is doing great. So I think I've gone way over now, haven't I, Jody? Questions?
We're good. We're good. We can move on to questions if you're good for that now.
Okay. Well, I had one more case, but I think
fine.
it's probably time for questions. Yeah.
Okay, sure. All right.
So yeah, thank you everybody though. I so appreciate, like I said before, I just so appreciate the opportunity to speak with everybody about something I'm very passionate about. So yeah, looking forward to the questions.
Yeah, thank you so much for the presentation. So our first question is, what is the specific barrier that you recommend for women when they go swimming? Do you have a link or a name for it?
I usually recommend them to get a ointment, so something that's got beeswax in it, and I prefer, something that's formulated with a calendula ointment so that they get that double improvement, something with some vitamin E in it. Usually there's something formulated like this at a health food store, and that works really well. It does really need to have that beeswax so it doesn't just wash off. And in worst case scenario, if there's not much around, they can use Vaseline, and I just tell them to wipe it off really well afterwards.
Okay, so that prevents the bacteria from getting in, really. I'm assuming the bacteria kind of then just gets stuck there or on the outside.
Well, it acts like a barrier so that they can't adhere to the mucosal surface around the opening of the orifice.
And then how does the chlorine specifically, or do you know, how does the chlorine actually affect
the immune system
or increases susceptibility?
Well, it's more related to the fact that chlorine has a documented impact on the immune system. I don't know the mechanism of action with that, but it's something that they can look up, and it's something that I see frequently. I've had cases where they had to go in a chlorinated location versus they had been in, like an ocean, a salt water or something like that. And, UTIs with the one, no UTIs with the other. We see that with upper respiratory tract infections with children as well. Kids that go in the pool more tend to be more, get more colds and flus as well.
Interesting. Okay. So next question. Thanks for the presentation. Very useful. Can you please re-explain when you would recommend each product or always a combination? So I think
that's a really great, that's a really great question. So the PACs is what I tend towards because it covers more bacterial species. And like I said in my presentation, although we think of recurrent UTIs being predominantly E. coli, it's actually potentially lower than that. It's potentially 50%. So there are, and it also not just only 50% being more or other species, 50% E. coli, but also potentially more polymicrobial. So there might be 2 or 3 pathogens working in concert together. So it is, I do really go towards the PACs, and unless a patient, it is always E. coli and they have used eMano successfully in the past, then like I said, I will do more of that discussion around, okay, let's make sure you're taking the right dose, the right frequency, and that way they can continue on with a therapy that's already working for them. But I do, when a patient hasn't had any, any of those, either of those products, I always start with the PACs.
Okay. Next question. Can you give some more examples of self-management tools you share with your patients, please?
Okay, so more self-management tools. So besides PACs, self-management tools. So we're talking about like the urinalysis strips, potentially.
I'm thinking maybe things that, as well as things that they could do, at home, preventative measures.
So I have an acute UTI handout that I give to my initial patients so that they have a bunch of strategies that they can try when they start with symptoms coming on. And that includes, it could be baking soda, because baking soda can really reduce the urinary irritation. Although we don't think about it, even Advil, even ibuprofen, although it's not, it's not great for their gut, it acutely can reduce that inflammation and help ease symptoms while they're waiting for their immune system to work, while they're waiting for their herbs to work, or their anti-adhesives if they're taken at a higher dose to flush out the bacteria. I think so. I'm not sure if they're also referring to when I was talking about the urinalysis strips, but having them check their urine if they start to feel symptoms, teaching them how to do it beforehand, how the urinalysis strips work and how to do the collection. And I also give them a rec. If a patient, hasn't really had many cultures done and we do want to know what that pathogen is and they don't have a standing order, I'll give them an open Life Labs rec, just with the 3 checked off, and just say, email me if you use it, and letting them know, it's how much, $28 a pop or whatever. And that way they can collect, and telling them to go to the lab and get some sterile containers and have them at home, so that they're not, they can do that quick sample and they can stick it in their fridge overnight, get up in the morning and take it to the lab. That's also part of the management, so that we do know what the pathogen is before they've started to try and eradicate it with, a whole bunch of herbs or whatever the strategy is going to be for that particular patient. So that's it. I hope that answers that question.
I think so. Thank you.
All right.
Next question. Dr. Girard, can you give your opinion on the safety and use of borax?
It has come up a couple times with patients asking me about it, and wonder what, I don't know about it. I'm just going to say that one is, I hear women are using it vaginally, and I say the same thing to them. Don't know about it. Maybe one day I will.
So what do you do for male patients with UTIs or recurrent UTIs, or is it just not that common? Is it along the same line as the recommendations for women that you mentioned?
So very uncommon. I've only had a handful of recurrent male UTI cases, and the workup is different. They do need a lot more testing to check those different reservoirs of bacteria. It is the same prevention strategy. We want to try and find, we want to find some sort of way to prevent them effectively for that patient on a long-term ongoing basis while we work on that bladder biome. But the potential for an anatomical abnormality is really high in these patients. And unfortunately, they all have their own specialty, and sometimes the full workup isn't always done. So it is really important to go through what imaging has been done with that patient and and especially with COVID, there was a lot of telemedicine with COVID. So there was maybe more delaying in doing the imaging. So making sure that's been done, and then doing the testing is a little bit tricky because you need a prostatic fluid sample. It can often be a asymptomatic prostatitis that is creating the uropathogen moving back up into the bladder and causing infection. There could be a skin bacteria. There is a small study that shows that although, the foreskin, underneath the foreskin, can be a reservoir for bacteria and that can ascend the urinary tract in men. So that is actually seen. Not very common though, again, very uncommon. And even in the semen, the infection can be in the semen, in the scrotum, and then it can again ascend to the bladder. So
okay. Would you please explain the connection with low vitamin D and UTIs?
Yes. So I'll just explain that again then. So when we have an E. coli invade the bladder, invade the urothelium, and the bladder, what happens is the bladder will initiate a shedding process, and then the damaged lining needs to regenerate tissue. Those umbrella cells, which are on the very outermost edge of the urothelium, they have to knit back together. And those tight junction in between the cells, they don't knit back together very well if a patient has low vitamin D. So that came out in the research I can't remember what the citation date was, but essentially, and then that incompletely healed barrier is then prone to another E. coli adherence. So
okay, makes sense.
Very important to correct that one.
Yeah, especially now, right, as we're getting into colder weather.
In the fall. Yeah, yes. This is the perfect time to check, right?
Yeah.
It's this is when it will be the best all year, is at the very end of the summer, and then that helps you decide whether or not you need to really up their dose, or they're on a maintenance dose, and or need it at all, right? Every now and then we come across probably someone that's too high. And and I am a big fan of doing the injections. It's a really great way to get their levels up quickly.
Okay. So let's do one more question. Actually, we have one more here. So how long do you keep patients on the supplements, acutely and preventatively?
Preventatively, I like to keep them on it for a year, because these recurrences can be so spread out, right? Some patients have 3 a year, right? Or 1 every 3 months. So in order to really see that we're getting things, like we're calming things down, and again, preventing that dysbiosis cycle, it is important to let them know that they need to consider this long-term. And especially in complicated UTI patients, this is then part of their daily regime, because unless something changes surgically, they are going to continue to be prone to their UTIs. I mean, if they've got a neurogenic bladder, they're going to need to cath, or they have an indwelling one, and that's not necessarily going to change unless they have some sort of major reconstructive surgery or a bladder stem implant. And so the two different categories, right? So I do it longer term, and that has better outcomes for patients, because I have seen it in practice where I get somebody really good for 6 months, and then 4 months goes by, and then I get an email and they say, I had to use an antibiotic and I wasn't taking my supplements, and now I've got a yeast infection and a UTI came after that, So
yeah.
It's really challenging to help patients understand that long-term strategy, because the gut biome does take a while, and if they're not very good at being compliant, then if they have something that's working for them, that's still better, right? That's still better to prevent. Every UTI we can prevent is so much better for them, and maintaining, if they do decide to use antibiotics, it decreases that chance of antimicrobial resistance forming, You know, that way they don't continue to develop those problems, and they can rely on the oral options, right? We talk about it. I talk about it with patients as saving, you know, saving it for when you really need it, right? Because there could be another infection at some point in the future. And if you're resistant to Cipro because you've taken it so many times for a UTI, but that would have been the best antibiotic for a different infection, then that's, you know, not ideal situation.
Right. Makes sense. All right. Well, thank you so much. That's it for our Q&A. Dr. Girard, I want to thank you so much for joining us this evening for the great talk. And it was great. I really learned a lot, and I'm sure that everybody else did too.
Thank you so much, everyone. Have a great evening, and hopefully I see you sometime soon.
Thanks.
Thanks, Dr. Girard.